GQ type of G protein coupled receptor. In the case of alpha-2, remember that's going to be presynaptic now, that's a GI. And in beta-1, it's a GS or a stimulatory one. That's the basic one that we talked about as an example last week. So don't let that push you away though. Let's dig in and figure out what's going on here. Because I really want you to be able to tie the catecholamine to the response, okay? That's the challenge here. So if you just take and look at the bottom right-hand corner of this slide, I think it will help you be a good place to start. So, in the case of the beta receptor right here, and you could put on your notes that this receptor right here, we'll go with both a beta-1 and a beta-2 receptor as well. It shows you just beta right there. You'll notice that it is tied to a stimulatory G protein coupled receptor. So, when norepinephrine and epinephrine interact with this receptor, what effects are you going to see? Well, first of all, you know it's stimulatory, right? So cyclic AMP is going to go up. You're exactly right. So if cyclic AMP goes up, as you can see right here, then you have a whole host of effects. You have a stimulation of myocardial contraction, okay, which I hope makes sense to you. Epinephrine binding to a beta-1 receptor in the heart increases myocardial contractility. You also have smooth muscle relaxation, okay? Remember I asked you in class last week, I said, hey, if somebody is having an anaphylactic reaction, right, and they have an EpiPen, you give them an epinephrine injection, why does it help them? What are they suffering from if they have an anaphylactic reaction? Yeah, bronchoconstriction, right? That's a big problem. They can't breathe. So they have an EpiPen, you administer the epinephrine, they can breathe. Why can they breathe? Okay? The bronchioles dilate, but why did epinephrine make them dilate? Well, that's shown for you at the right-hand bottom corner right here. The epinephrine which you gave is going to interact with a beta-2 receptor, in this case, in their lungs, and lead to smooth muscle relaxation, right, and bronchodilation. That's a great thing. That's what you want. The reason I tell you these examples is because sometimes I think it helps for you guys to think about it like that. Give you a real-world example. And that's a good situation for epinephrine right there. So at the bottom here, you see smooth muscle relaxation. You also see some metabolic effects as well. Let's go back to my example of the cat, okay? The cat is in the MRI. We've given an alpha-2 agonist in our case. There's a variety of ones. I'll tell you some of those in just a little while. And the cat is sedated because we have shut off norepinephrine production in the brain. We've shut it down. We've dramatically decreased it. How does that work? Well, notice here that typically what you have is in the body right now, norepinephrine will swing back onto that presynaptic receptor, activate it, and that leads to an inhibition of neurotransmitter release. It's a negative feedback. It's inhibiting norepi release from the presynaptic nerve terminal. You could also give a drug, remember the drug that I just talked about, which will interact with the alpha-2 and inhibit norepinephrine release, right? How does it do that? It's not a GS event, not a G stimulatory event. It's a GI, right? It's a GI. And there you see it right there. It's decreasing in production right here of your cyclic AMP, okay? Also having effects over here on calcium release as well. All of this together leads to this dramatic effect that you see, inhibiting norepinephrine release, but also notice here that you have smooth muscle contraction. The opposite of what you saw right over here, right? When you stimulated cyclic AMP production, okay? One more little pathway to think about. Now I'll let your mind get away from the pathway part of this, because this will kind of, for you to think about it early on Monday morning, it'll be a little challenging. But let's look at alpha-1 now, the third one, okay, on your left-hand side there. Hey, what's happening here? Well, in the case here, epi and norepi are binding to this alpha-1 receptor. You'll notice here that it is a GQ. Okay, we didn't talk about GQs when we talked about signal transduction last week, but let me tell you what happens here. These receptors right here are tied to They're tied to phospholipase C, as you can show right here in the pink, okay? That leads to the production of a number of intracellular signal transduction mediators, not cyclic AMP in this case. In this case, you're talking about IP3, inositol 3-phosphate, as well as DAG, diacylglycerol. You don't necessarily have to know that, okay? What's important about those two signal messengers in comparison to your cyclic AMP is that they are going to stimulate, as you can see right here, the release of intracellular calcium, and that is going to lead to vascular contraction, okay? And you guys should all know that norepinephrine, when it binds, this is so important, okay? When norepinephrine binds to the alpha-1 receptor, that leads to vasoconstriction, okay? And that's how it does it, okay? Norepinephrine binds to the alpha-1 receptor, leads to the release of intracellular calcium and vasoconstriction. Everybody follow me? If you, so many other drugs I want to tell you about, I'm going to fight that urge to do that, because I want to give you another example, but just think about that, okay? Think about what's happening there as we go through this. Now, over here to the left, let's just make sure we're clear on this. Cardiac muscle, again, increased cyclic AMP, you get contraction, okay? Also, on smooth muscle, if you increase cyclic AMP, you get relaxation. This alpha-2 that you see right here, is everybody following me where I'm circling this? Let's move that. Let's move that, because that is going to confuse you. So this little alpha-2 that you see right here, okay? Let's put it down here at the bottom, okay? And I would write on this screen, but I will mess it up. Move that alpha-2 to the bottom, and just beside it, write decrease norepi release. Okay, just write that. Decrease norepinephrine release. Because that's really what I want you to know. And that's how you're going to use those drugs. So at the very bottom, move that alpha-2 to the bottom of this list. Don't include it where it is right now. And put decrease norepinephrine release. This slide is important for you guys. It's important. Now, I'm going to show you a slide now, though. And I don't, it is probably, it's considered to kind of be the complete version of this. So, I'm not going to go through it with you in detail, but what I want you to understand is that this slide right here is a synopsis of what we just talked about. If you look, you have the same receptors here. Remember, you're talking about 4 receptors. You have alpha-1, remember, postsynaptic. Everybody follow me on that? That makes sense, right? Alpha-2 presynaptic, right? Presynaptic. Beta-1 post, and beta-2 post. Okay, is that clear to everybody first of all? Okay. Now, underneath each one of them is the signaling events that I just described for you. Okay, remember, alpha-1 is coupled to GQ, phospholipase C, IP3 diacylglycerol, right? Increase in intracellular calcium. Over here on the beta-1, beta-2 side, you see this is a GS, so you get an increase in cyclic AMP, right? Alpha-2 right here, okay, you'll notice that it's coupled, it's going to inhibit adenylate cyclase. Remember, it's a GI, okay? So that part of the slide is really just a reiteration. But underneath each one of these, I've included a complete list of events that are tied to them, okay, that are tied to them. It's too much for you this morning to think about all of them, but I want to highlight a few so that it will allow us to continue our discussion for the rest of the morning, okay? First of all, if you just look with me on the alpha-1 side, remember, anytime I'm in front of you and I say anything about alpha-1 stimulation as an agonist, you should think vasoconstriction. Okay, so let's look at this list right here. I want you to underline vasoconstriction. Anytime I'm in front of you and I say, we're going to activate alpha-1, immediately the first thought in your mind is vasoconstriction. If I tell you that you're blocking alpha-1, you should be thinking vasodilation, right? Okay, stay with me on that. That's an important thing to think about. And I'm going to leave the rest of the list right now, I just want you to think about one thing at a time, okay? Alpha-1 vasoconstriction. Now let's go with me to the right-hand side of the picture, over here to the beta-1 side. Anytime I tell you that you are an agonist and you're activating the beta-1 receptor, okay, you should think increased myocardial contractility, okay? Increased myocardial contractility, increased myocardial rate. Do you see that right here? Stimulate contraction, I can't talk this morning. Stimulate heart rate. Okay, so underline those. Very, very important to you. Okay? Anytime I walk in and say that this drug right here is a beta-2 agonist, you should always think dilation. Okay? I gave you the example earlier of epinephrine dilating, right? The pulmonary, the bronchioles. Well, look at the list right here. The reason it does that is because it is smooth muscle relaxation. It's at the level of the bronchioles, but you're also going to see it affects on the vasculature as well, and it's quite profound. I mean, it's quite profound. So anytime you think about beta-2 activation, think about dilation, okay? Anytime you think about beta-1, think about myocardial contraction rate. Anytime you think about alpha-1, think about vasoconstriction. Now we've ended up with the good old alpha-2, right? It's sitting right there in the middle of your table. What do I want you to know about alpha-2? Well, the chart is a little bit confusing, I think. So let me just point out one thing to you. What do I want you guys to know about alpha-2? I want you to know that if you're an alpha-2 agonist and you bind to that receptor, you decrease norepinephrine release. That's what I want you to know, okay? Because that is how you guys are going to use alpha-2 agonists as sedative compounds. So let's look at our list right here. Everything is fine, but when you get down here to number 3, inhibits release of norepinephrine, that is the one that I want you to think about. I want you to circle that, okay? I want you to circle that and think about that, because that is your critical feature of that point, okay? So you might be saying, well, hey, you showed us this whole chart, and now you simplified it. You've given us one thing for every one. And here's the reason I do that, because I remember when I was like you and I was learning this chart. I may have already told some of you the story of when I learned pharmacology. I had great memories of it too. But when I saw this chart, my inclination was, oh my gosh, I gotta go through and memorize everything. And that's true. I mean, that's true. But at least in the beginning, when you're trying to understand the foundation, you've got to get a grasp on some major features, okay, first, okay? So I gave you those major features first. And I'm going to show you a picture of a graph here in a few minutes, and we'll tweak that a little bit. And I think that's real important that you think about. Okay, this is the graph that I wanted to get to. I'm not even sure what time it is.
5 minutes.
5 minutes, thank you so much. Okay, good to introduce this. Did I tell you about my pharmacology instructor, by the way?
Yes.
I did, yeah. Well, this is the graph that I was telling you about. I remember seeing this graph vividly and walking out of class, following him out of class, saying, listen, I'm not sure I get all of this. And he says, then you need to go back and think about the receptors, okay? He said some other things too, but I think that was the gist of it all, okay? So, here's the thing. This is showing you intravenous administration. We're now to your first group of drugs, guys, okay? It's going to show for you here in red. You're now going to intravenously administer to a dog norepinephrine, epinephrine, and a compound over here on the right that's not on your model drug list called isobutyrenol. So you're going to do that, and you're going to monitor some vascular and cardiac parameters. What I would do if I was you, and this is the way that I eventually learned this, is I drew a line underneath PR right here, all the way across. So the effects at the top part of that chart are going to be your vascular effects. The effects on the bottom are going to be your cardiac effects, okay? And I've written them over there for you on the left just in case you're not sure what the terminology is. This chart right here is in every veterinary pharmacology book you will pick up, It will be there for you, because it's trying to get you to understand what happens with these compounds and what happens with the receptor interaction, okay? So, here's what happens. You're looking at blood pressure, you're looking at femoral blood flow. That should be flow, not femoral blood pressure. Please change that. That should be femoral blood flow, okay? Femoral blood flow, renal blood flow, peripheral resistance, myocardial contractility, heart rate, and cardiac output. Now, here's what I want you to understand, and please raise my hand because I'll run out of time, okay? When you're talking about these effects, the old charts and the old books did not have the receptors on them, and that was my big struggle. I looked at this picture and I kept thinking, man, why is norepinephrine increasing blood pressure? I mean, why is isobutyrenol decreasing blood pressure? I had no idea. Well, because the old version of this chart did not have the receptors on them. The new versions all have them because they're exactly right. Now that I told you those really points on that other chart, and you see the receptors up here, you guys should be able to put the two and two together. But you can't if you don't know what the receptors are, right? So let's just do one quick example, then we'll take a break, so I know we're running out of time. Let's do the easiest example first, norepinephrine on the left, okay? Remember, norepinephrine binds to the alpha-1 receptor. What does the alpha-1 receptor do now? That's great, okay? Vasoconstriction. That's what it does, okay? So, based on that little tidbit that I told you, let's see what happens. Norepinephrine is given IV. You see an increase in blood pressure, right? Because it does what? Vasoconstriction, right? Alpha mediated. Okay, you see the alpha receptor right there. Because it constricts the vessels in the femoral region and the kidney, what happens to femoral blood flow and renal blood flow? Decreases them, right? That's what you see right here. You see a decrease in femoral blood flow and a decrease in renal blood flow, right? Does that make sense to everybody? Overall, that leads to an increase in peripheral vascular resistance. So when you gave IV norepinephrine, travels through the body, binds the alpha-1 receptor, constricts all these vessels, that's a big issue, right? Your blood pressure is going to do what? Way up, right? And you see it here at the top. See, it's a dramatic increase in blood pressure. But I want to emphasize to you is that good old norepinephrine can also bind to the beta-1 receptor. What did I tell you about the beta-1 receptor? Increase in heart rate, increase in contractility. So when it does that, look at what happens. You see an increase in myocardial contractility, and you see this little strange effect on heart rate. Okay, you see heart rate start to go up, but then it fell back. And that R stands for reflex bradycardia. And I'm going to stop right there because I'll keep on going. But why, the question for you guys to, I guess, simmer about during the break is why do you see reflex bradycardia when you give norepinephrine? And remember what is happening on the vascular side. Remember this. Okay? You guys take a break, and when it's time, we'll kick it off again.